I'm Cherie Peterson, and on behalf of ARUP Laboratories and its Institute for Learning, we're pleased to have you attend this webinar event on the importance of clinical information for optimal genetic test selection and interpretation, presented by Christine Miller. Christine Miller has been a genetic counselor at ARUP Laboratories for over 10 years. In that role, she functions as a liaison between the laboratory and ordering healthcare providers. Ms. Miller received a Bachelor's of Science in Biology from James Madison University and a Master of Science in Genetic Counseling from the University of South Carolina. She is a diplomat of the American Board of Medical Genetics and the course master for the Genetic Counseling Laboratory Rotation Program at the University of Utah. Ms. Miller established perinatal clinical genetic services at LDS Hospital, McKay Hospital, and the Utah Valley Regional Medical Center. It is now time to turn our conference over to Ms. Miller.
Thank you, Cherie. So what I hope today is that you'll learn understand further the relevant clinical information that you provide a laboratory and how we use this to not only interpret your genetic test results, but also help make suggestions if we feel like a better test could be ordered that might be either financially better choice or just clinically more appropriate for the patient. We'd also like to help you understand the role that genetic counselors can help play in both pre- and post-analytic test review. In 2009, the CDC published a report specifically talking about best practices for molecular genetic testing for heritable diseases. What many people don't know is that when you test for molecular genetic disorders, it's very critical to have this type of information, the clinical information provided to the laboratory. There's many other tests done in laboratories where they don't need to have information up front. I think that's the kind of education we need to give healthcare providers so they understand how we could help them better if we had this information. CDC reflected that there was more errors occurring in both the pre- and post-analytic phases and then in the actual analytic process itself. So most people assume that when there's errors in the lab, it is really at the bench work, which that is not usually the case with a molecular genetic test. There was a study of APC gene testing that found that testing was unwarranted in approximately 17% of all cases that were ordered. So the CDC encouraged laboratories to help healthcare providers with appropriate test selection, to instruct healthcare providers on what type of patient information actually needs to be provided to help laboratories offer the best test and the best interpretation for the patient. And genetic counselors or other laboratory personnel should be available for consultation with healthcare providers for the best test selection and interpretation. And other pre-analytic issues were informed consent should always be offered for or encouraged for all molecular genetic tests. And in that informed consent, it should definitely discuss that the results are not only important for the patient, but for other family members. And laboratories should establish policies to assess if there are problems with test ordering and how to go about correcting those problems. So again, as I said, analytic errors are not the main problem with molecular genetics testing. It's already a regulated area by CLIA, and when it's been looked at, errors were occurring in approximately 1 in 1,000 to 1 in 2,000 samples that were tested. But again, now we go to the post-analytic phase of testing, and we have more errors that are occurring, and a lot of that has to do with report preparation and interpretation. Again, if healthcare providers understood how many limitations we have in interpreting the same type of a result, if we don't have clinical information, they would understand why our reports may lack completeness or, the content might not be accurate if we do not have the clinical information to help interpret what results we're finding. So I'm going to give examples of these types of things throughout this presentation. We reviewed our tests. right now, genetic counselors at ARUP review all the molecular sequencing and deletion duplication tests that are ordered. We also review selected cytogenetic and biochemical assays. We went back and looked at 21 months of data that we collected between April 2010 and December 2011, so a 21-month period, specifically just for the molecular genetic heritable disease testing. And I'm going to share some of the information just in the molecular area. What we found was that approximately 86 tests are modified per month, which includes both cancellations and additions. The average cost savings per month was greater than $60,000 from cancellation of erroneous tests that would not have been helpful, and which translates to a savings to hospitals, insurers, and patients of close to $750,000 a year. Specifically, if we broke up what types of things are misordered, or about, again, 28% of our complex molecular genetic tests during that time period, 35% of them were canceled. They were just totally at the wrong test, and then we ordered the correct one. 26% of the time, we were able to cancel the test, but the correct one couldn't be ordered because either the sample type wasn't correct, like to change it to the different test that was needed, the specimen was just a different type, or maybe after talking with the doctor, it was decided that other things needed to occur first, maybe going to a geneticist or something might have been more appropriate than just forging ahead with testing. 14% of the time, we were able to cancel a full gene sequencing type of test and do a targeted panel that was more effective and cost effective. And 13% of the time, we were able to cancel a sequencing test and order a targeted familial mutation test. So usually instead of, like, for instance, sequencing a gene with 20 or 30 exons or 50 exons, we were able to maybe just look at a single exon where we know that the familial mutation exists. And 7% of the time, we were canceled a test that came in for a specific test on our menu, and we didn't feel that it was appropriate testing, and facilitated a send-out order to another molecular genetics lab to do the appropriate test. 5% of the time, we could see that there was a duplicate test order, either it's been done a year ago, 6 months ago, or maybe sometimes it's 2 tests are ordered where one of them is embedded in another test that's just ordered on the same thing that's going to be a duplicate order. So lots of different reasons that we look at, and that just gives you a good breakdown of that. So if I give you specific examples under each of those categories, I don't have to make them up. I just, because we have them so often, we just kind of think about what are some of the things that happen. So in the ones where we cancel incorrect tests and order the correct one, I'll give you a few examples. Would be like when you're ordering, we'll see a test order for hereditary hemorrhagic telangiectasia, where the physician actually wants the hereditary hemochromatosis panel. How do we know that? Well, we don't know that unless we try to get a patient history form or some clinical information about what is this patient's symptoms of HHT. And you can see why, given the acronyms for those disorders, why they're probably misordered sometimes. But unless we have clinical information, we wouldn't know. We also often see, for instance, the alpha globin sequencing test is ordered, but what's really neat is the alpha thalassemia 7 deletion panel. So again, it's a common, alpha globin sequencing is a common screening test. The panel, the deletion panel is a common screening test. The sequencing only picks up 5 to 10% of alpha thalassemias, and I think it's just not common that the deletion test is more sensitive, and so I think that's maybe why the ordering errors are occurring in that disorder. As far as Rett syndrome, we see sometimes people ordering Rett syndrome, MECP2. They really want the MECP2 gene, and sometimes they've actually ordered Rett gene, and they want the MEN2 testing, so the multiple endocrine neoplasia. Or Lynch syndrome testing, we often see like one particular gene ordered, but they actually need another particular gene. So there's 4 different Lynch syndrome genes. So again, looking at one versus another is going to be a completely different result. Talking about like some of the incorrect tests ordered, but we can't change it. I'm going to give you a couple examples. One of them might be we see galactosemia testing ordered when actually they wanted infectious disease like Aspergillus galactomannan ordered. Not uncommonly, I see factor 8 or factor 9 gene sequencing ordered when actually they just want the activity level. And often you can see that when they're ordering both factor 8 and factor 9 gene sequencing. You're like, okay, usually people know more specifically what they want as opposed to sequencing multiple genes for hemophilia. So you sometimes can tell that just from looking at the order, but most of the time it really helps still to have this clinical information so that you can help that practitioner get what they want. 14% of the time when we cancel this full gene sequencing and add a targeted panel, rarely commonly in that group is the CFTR or cystic fibrosis gene sequencing being ordered usually on a routine OB patient. So, like for instance, the American College of Medical Genetics recommends doing a 23 mutation panel because when you sequence, a lot of times you find a lot of variants of unknown significance. And that's not usually what an expectant couple wants to know is they may or may not be at risk. The turnaround time with sequencing is a lot longer. It's usually weeks versus, 3 to 5 days with the panel. The cost is also significantly higher. So you really want to, if the test is really for a routine OB patient, you would want to do that type of panel as opposed to sequencing. And then, about 13% of the time, we were able to cancel full gene sequencing on the misorders and order a familial mutation test. This is really common with autosomal dominant and X-linked disorders. So things on our test menu that might be like the, HHT, Rett syndrome, P10, factor 8 and 9. Lynch syndrome really commonly. So a lot of dominant. So if you just look at any test menu where they have really common dominant or X-linked disorders, if there's a known familial mutation, laboratories offer a targeted sequencing of that gene. You just have to have a copy of the test result of the relative. Other misorders included the 7% of incorrect tests and I'll give you an example of what we realized at ARUP is we brought on neurofibromatosis duplication deletion testing before we brought on our sequencing test. And so that created problems, even though we were very clear about what we were doing with this duplication deletion, and it picks up about 6% of NF mutations, and we brought it on for severe cases. But we were getting a lot of orders specifically for that. And when we contact the doctor's office, they really wanted the sequencing or the 89% detection. So we sent those tests out until we were able to bring on that test in-house. So again, it's monitoring when you see your own testing. If we hadn't been contacting those to try to get clinical information and what tests did they desire, we wouldn't have known that that was what they desired and what the appropriate test was. 5% of the time, we notice a duplicate test order. And, in genetics that you rarely need to repeat testing, obviously, unless you think that there's a sample switch or the clinical symptoms don't correlate with your molecular results. A lot of times when we contact the doctor's offices, you could get different reasons for that. Sometimes, it was ordered by the same doctor's office, but they couldn't locate their previous results or didn't know if it actually had been ordered just kind of facilitating healthcare providers getting results can sometimes make the difference on a few of these tests that didn't need to be reordered. So again, it really translated just in the molecular testing to over about $60,000 a month, or about $750,000 a year. And if we went back and if you wanted to say, by volume, what were we seeing? A real common test, if you wanted to identify what was happening maybe in your laboratory, again, just recognizing that the cystic fibrosis sequencing and deletion duplication testing is a real common misordered test for OB patients. So just to review that when that test is being done, it's really more done for symptomatic individuals. And then Again, alpha-globin sequencing, as I discussed earlier, is not the first-line test. The test for screening for alpha-thalassemias is this a deletion panel. The sequencing will not pick up those deletions. Neurofibromatosis, I think just specific to our laboratory is why it was being misordered, but we were able to correct those. And then the Lynch syndrome gene, whenever that's ordered, even though it wasn't as high as some of the other ones, to me, it's a real critical thing because it could be life or death when you're telling someone they do or don't carry a specific familial mutation, and therefore they may not go on to screen for a hereditary cancer appropriately. It's pretty scary. So that, maybe 8% of all those tests were inappropriately ordered. And sometimes we a fair bit of times, about 12% of the time, we had sequencing for a known familial mutation ordered, when in fact, there was no known familial mutation. In other words, there was a familial condition going on, but no one in the family had actually ever been sequenced or had duplication deletion testing. So they needed to understand that first we need that type of result, and then we can test every other person in the family much more cheaply and targeted, but that does need to be done for at least one person first. So when you're performing test order reviews, you must have clinical history. Otherwise, you can't understand why the test was actually ordered. And most laboratories that perform molecular genetic tests do have this information that's requested either on their consent form or on their test requisitions. ARUP does create a custom patient history form for each test. And so the helpful information, if you were going to create these forms that, to make sure that the providers were giving you what you want, is generally what you want is the contact information for the provider. And practice type can shed a lot of information too. I mean, if you're getting a test order from a pulmonologist and it's the CFTR full gene sequencing, it probably is a symptomatic patient. Obviously, you don't know without the other information, but it's a good guess right off. You would like to get patient symptoms, any other supporting test results that they've had, like sweat chloride testing, or any family history of this particular condition, DNA results from affected family members, because obviously if you have those other test results, you're going to be able to do targeted testing often. And I really like to know, even if it's not the test that the actual doctor's ordering on the form, I like them to indicate what test are they trying to order. That way, it's a double check of what test was actually ordered. You can see this is what they really wanted. So to give you an example of our history form just for Lynch syndrome, it starts off with the patient's information, then the physician's information, if there's a genetic counselor involved, ethnicity of the patient, if the patient's been diagnosed, what type of cancer and what age, if they've done any specific microsatellite instability testing by PCR or IHC, we get a very good idea of the likelihood that this is very targeted. For instance, for that particular gene, we ask what genes have been tested, so we know those types of results that might have influenced the director when they're trying to interpret the results, if they know what the results of prior tests have been. And then the bottom part of the form, we ask about specifically family histories of cancer, because maybe this patient has had cancer at all, and it's just all based on family history. If so, what are the relationship of the people, what's their age, and do they have our test result you want to attach here so that we can do a targeted test? And finally, at the bottom, we list the specific genes for Lynch syndrome. So if you're looking for, you can circle that. It's really easy for us to see that. Make it easy on the provider so they can easily circle these things or check them off. And then, or do they want the deletion duplication, or do they have a familial mutation that's known? So just being just very clear about what you want. I'm going to give you a few examples now of how that clinical information does help us guide practitioners to the best test. So, for instance, we had an MSH2 sequencing and deletion duplication test ordered. There was no clinical information provided. When I contacted the healthcare provider, we learned that the patient's brother had Lynch syndrome. Well, I anticipated there must probably be a reason that they're ordering specifically MSH2, but then I got excited, like, okay, if the brother has it, then maybe you can get records so we can do custom testing, which is a lot cheaper just to do that targeted exon members instead of a whole gene. The healthcare provider was able to get that result, and when they sent it over, noticed that it was actually the MSH6 gene, not the MSH2, and we did get the specific mutation involved. So we were able to change the test to the targeted sequencing, but not, again, of the MSH2. So lessons from that case are, if we ran the wrong test, we just sequenced the whole MSH2 gene, we would have spent a lot more money. The interpretation would have said there wasn't anything pathogenic there probably, and then the patient wouldn't have got the appropriate screening. That's the biggest harm right there, is then they would assume, I don't have this, whatever my brother has, and they wouldn't be, and we still don't know if they have what their brother has if they don't do the appropriate test. So it's really good to get records and to know what you're testing. And that is not an isolated example. That's happened to me multiple times, that same scenario. With cystic fibrosis, so I'm just going to briefly go through this for people who aren't real familiar. Autosomal recessive condition requires 2 mutations. ACOG recommends this 23 mutation panel for OB patients. The panel has varying detection rates depending on your ethnicity. So if I see a test come in for sequencing, CFTR gene sequencing on a 26-year-old, I'm thinking, wow, okay, she's a prime candidate for being an OB patient just based on her age and her gender. I'm thinking, okay, well, convince me that she has symptoms. Well, we have no clinical information that came in with it. So we're going to, because it is a sequencing test and we have no clinical information, we are going to contact the provider. So first thing we notice when we do, it's an OBGYN. So now I'm even more suspicious. Is this the right test? Is this patient really symptomatic, or is this a routine? So we contact them. We found out it is routine. There was no symptoms, no family history, and just the wrong test is just selected. So we're able to cancel the sequencing test and order the panel. Give you another example. This is a recent example of the CFTR sequencing test that was ordered. This was on a newborn. So I'm thinking, okay, we don't know if maybe this kid has symptoms. We don't know, but it probably might be the correct test because it's not a screen, probably. So we called the healthcare provider, and I learned in this case there was an African-American infant that had an affected full brother so the brother had cystic fibrosis. I really encourage them, please get a copy of this brother's DNA result, because unless we happen to sequence and find 2 mutations, we're not sure how much of a rule out we're going to be able to give you. I'd much rather be able to do targeted testing for the specific mutations. So they were able to get back to us and said, in fact, he has the F508, which is the most common deletion in the gene. It's a small deletion that's picked up by sequencing. And there was a large deletion of exons 7 and 8 in the brother. And so the F508 deletion, which is small, would have been picked up by the sequencing, but it's a very expensive way to pick up that common mutation, because you could just pick that up on the common mutation panel. The deletion of the large deletion in the sibling would not have been detected by sequencing. It requires the large duplication deletion test. That would have been missed. So overall, if you had done the sequencing, you'd only picked up one of the 2 mutations. You'd also wasted a lot of money because you only needed a basic panel to pick up that mutation. And you'd still need to do that duplication deletion test, and you wouldn't know. So in this particular case, the infant was affected, and I'm glad I got the clinical information, because we were able to provide the diagnosis, which we wouldn't have been able to do. We would have said, 1 mutation detected. We're not sure if this kid's affected, but blah, blah, blah. So it's really helpful to actually have that information on another family member and to document it. Give you an example of another scenario. So for Marfan syndrome testing, often he will be ordering the FBN1 gene sequencing. At least in this particular case, that's what was ordered. It was when I looked at the case coming in, it's a 1-year-old asymptomatic male. So I'm thinking, why are they testing this baby for Marfan's with no symptoms? When I called the primary care physician, he says, well, the father of the baby has a clinical diagnosis of Marfan syndrome. Not by him, but he said, he's telling me he has Marfan. but he hasn't done any kind of molecular, because I was asking, is there a result? No, we don't have anything like that. So I explained how if we tested this infant and we found no SBN1 mutations by sequencing, we couldn't rule out a diagnosis. Even if we did duplication deletion testing, which might add a few more percent, we still couldn't rule it out. I think the largest reason is we don't really know the security of this diagnosis in the dad. So I really encouraged them to maybe have them send the dad to a geneticist, or if they can't get him into a geneticist, at least test the dad first for the SBN1 to see if there's a mutation we can identify before we make any assumptions about any kind of negative test in a baby. We haven't run it, but so what we did was they ended up sending in a sample on dad for both sequencing and del-dup, and he was negative. So what does this mean? I don't know. It could mean that he doesn't have anything. It could mean that he has some other condition. It could mean that he has Marfan's and it's not detectable. It means a lot of things, but all it means for sure for me is that testing the son for the same condition is not going to be helpful. And it doesn't rule it out. So if you're still worried about what this man has, then he needs to be evaluated again before any testing. Now I'm going to give you a little brief overview to give you another couple examples of test order errors. Hemophilia A, fairly common genetic condition, usually again causing things like spontaneous joint or deep tissue bleeding. It's classified as severe, moderate, or mild based on the activity level. So factor VIII deficiency, that severe is less than 1% activity, moderate 1 to 5%, mild 6 to 35%. And most people who have hemophilia A or B, they can tell you if they have severe, moderate, mild. They know their disease, what they have in the family. So that's important to ask family people when they're getting testing, because another family member has hemophilia. So, but what makes the testing a little more complex is there's several different types of mutations in the F8 gene that actually cause hemophilia. A real common one that is responsible for over half of factor VIII gene mutations is a large inversion. So there's a couple of large inversions, but one particular one. So if you test for both inversions, you're going to get about 51% detection rate. But these inversions cause severe hemophilia. They don't usually result in moderate or mild hemophilia. Whereas any kind of sequence variant, like if you're doing sequencing, that can cause severe, moderate, or mild hemophilia. And then usually the large duplications or deletions are going to be causing severe hemophilia as well. So just knowing that in the gene is going to help you select the best test for families. So these are we have these cases come in every day, but to give you an example, so you have a 25-year-old female where they have factor VIII sequencing is ordered. And if you look at the patient's family history, it shows there was a maternal uncle who died of severe hemophilia A. Well, if I know that, and there's not been other testing in the family to say what, if they've already looked at for inversions, or if they haven't, I want to start with the inversions. I don't want to start with sequencing, because the inversion test is a very targeted, inexpensive test, and that's where I want to start. It is a 50% chance I'm going to get my answer and not have to go on and do any sequencing or deletion duplication testing. So we're going to cancel the sequencing and order a test that's an inversion with reflex, if necessary, to the sequencing, and then reflex to do del-dup. Another example, you have a 5-year-old mildly affected boy with factor VIII deficiency who has about 10% normal activity. They had ordered the inversion with reflex to sequence with reflex to do del. Well, given the fact they know he's mildly affected, I really think all we need to do is the sequencing. I don't really want to start with the inversion. I don't really think we're going to need to do the del-dup. I think we'll start with it is more costly, but I think that's where the bang is going to be on this case, where we're going to identify the problem. So that's what we're going to do. So, how could, if you were working at a large reference lab, how you could put some of these things into practice would be, you would create custom patient history forms for the test that you're performing in-house, specifically asking questions that are going to help you help whoever's ordering this test select the best test to to have the, best detection rate, at the same time keep the lowest cost. The lab can extract DNA on every one of those tests, and that's usually a very small cost to extract DNA so that you have a day or two to try to identify this information, get the clinical information, and make best test selection. So either the genetic counselors or someone else in the laboratory who's reviewing these tests could then instruct the lab to say, yep, run it as ordered. It looks like it's the perfect test. Or I think we need to contact the provider and cancel the test and reorder. Obviously, you do that in consultation with the healthcare provider to make sure there's not another reason they're wanting to do that test, and to hopefully explain why you're thinking that another test might be more appropriate. What if you were in a smaller hospital or a send-out lab? Because, a lot of hospitals can't be doing, thousands of these tests. So they have to send out a lot of tests. And I would think that you'd want to require the healthcare provider who's ordering the test, especially for these molecular genetic tests or any genetic test, not just molecular, to actually provide the clinical information with the test order. Maybe complete the patient history form. So if the doctor knows which lab they're sending it to, then they should be just completing that and sending it to the send-out lab. If they don't, I would think the send-out lab would want to send that copy of the patient history form and send it back to the healthcare provider and say, we need this clinical information, because even at that point, they could review the information and decide, is that the best test? If you have a genetic counselor on site in your hospital, maybe they're available to come down and review these for a half an hour a day from, OB or cancer or peds. It wouldn't take a large amount of time for a individual hospital to do this, but I think it could result in a lot of savings. So why do I say keep going back to genetic counselors? I think that they're an unrecognized profession that, even though there's still only 3,000 of us out there probably practicing in the country, we're kind of spotted all over in some of the larger medical centers. And we are master level trained and specially trained in interpreting clinical medical genetics. It is a terminal degree. There isn't a PhD in genetic counseling. As far as the NSGC, it's in our scope of practice as of 2006. That genetic counselors should be able to order tests and perform clinical assessments in accordance with local, state, and federal regulations. A lot of genetic tests are ordered by healthcare providers that don't have a lot of formal education in genetics. And it's up to the laboratories to help guide them. And if you can use a genetic counselor, it seems like that might be an obvious thing to incorporate. Just to give you, again, a little bit more information on genetic counselors, in 2013, there's about 27 accredited programs. 3 in Canada, they're accredited. 80% of genetic counselors do work directly with patients, so it could be right there at your hospital. 10% work in diagnostic laboratories in lots of capacities. And what are the people who are actually seeing the patients face-to-face mainly doing? Well, they're either working a lot of times in these high-risk pregnancy clinics, but they also work, in pediatrics, birth defects, mental retardation, other heritable disorders that are running in families, work with individuals with psychiatric conditions and familial cancer. It's a very common area for genetic counselors now. And what's the actual process? So what do genetic counselors do when they're seeing patients? They review a lot of medical records. So that is something that we won't hesitate to do, is to actually get the family's medical records to document what is going on in this family. So we don't expect it to be a really quick process. We expect that is what's needed to actually do the correct assessment. So we perform the risk assessment, discuss disease management, treatment, testing, and facilitate the best decision for that family, which is often different. One family makes very different decisions with that same information than another. So I'm going to shift gears here now, and instead of talking about how that clinical information is so valuable in helping laboratories make the best suggestions for healthcare providers on the best testing, I want to talk about how that clinical information is now used on the post-analytic review. What do we do with that information, and how important is that information for interpreting the results that we get? So, again, the kind of information we need, clinical information on the patient, family history, and any kind of affected relative test results. Those are the most critical things. And so, I'm going to go talk a little bit about cystic fibrosis. Often people say, why do you need to know this? Why do you, Well, we're going to put a different interpretation on a test that's a carrier screen versus one where the patient actually has disease, whether that be classic disease or atypical disease, where they're more mildly affected. Is there a family history of this? If there is, again, we have to know exactly how the person is related to them, if the person is actually symptomatic or they're just a carrier themselves, and do we know what their mutations are? Obviously, that's the golden ticket. We want to get mutations if we can. And then finally, what's the ethnicity? And why do we need to know that? So I'm going to take you through a few examples of that with the cystic fibrosis, just looking at us trying to interpret the same result in, for instance, a cystic fibrosis panel. So let's say we have a cystic, these are, again, not made up. We get so many of these. Cystic fibrosis mutation panel, 4-day-old female, and you find a single mutation. So how should this be interpreted? Well, we don't know if she's symptomatic. We really don't know why she was tested. If she's symptomatic, should we say, we might have missed the other mutation, you need to do sequencing? If she's asymptomatic, why are they testing her? Should we just say she's just a carrier probably? Or, what do we say? So we call to get information on the case, and we find out that this mother actually is a known carrier of this R553X. So this is not an uncommon situation where someone in pregnancy was offered a carrier screen, finds out that they actually have a mutation, but their spouse cannot have testing because they can't afford it. They're not covered by insurance. So, it just as a Hispanic father refused the testing. So she's gone through this pregnancy knowing that she has this higher risk. They might not know exactly what that risk was. So often they want to test that baby when it's born. So the prior risk would be her chance of being a carrier, which we know she's a carrier. So it's the 1 and times the chance that the dad is a carrier, since he's Hispanic and hasn't been tested, is 1 in 46, and then the recessive inheritance. So the risk is about 1 in 184 that the actual her baby would be affected. We can actually do, after we've done testing and found that single mutation, we can do a Bayesian analysis to actually give you a very precise risk estimate to the family or to the healthcare provider who's going to be communicating this result with the family. I'm not going to teach you Bayesian analysis here, but I'll just take you through briefly what we're thinking. We're wondering to ourselves, what's the chance the father passed a mutation, but we didn't pick it up because the panel is not 100%. So we could go through, and again, the chance is 1 in 46 that the dad has a mutation, and then half chance he would have passed it. And then what's the chance for the condition that we would have missed it? We have about a 73% detection rate on our panel, so 27 out of 100 cases, if the baby was affected, would still look just like just mom passed it. And when we come down through the calculation, we actually come to a posterior risk of about 1 in 340. So that's the chance this kiddo is actually affected, even though there's no symptoms at birth, which you wouldn't really necessarily expect. So probably my report interpretation is going to not only say specifically what that risk is, but I'm probably not going to recommend necessarily extra testing for this baby unless it should develop symptoms. So then I would have a low threshold for, doing additional testing if there were symptoms. But if not, I'm not going to necessarily recommend additional testing. So let's go with another case. Same scenario. We call on the case that there's just a single mutation identified, the R553X, Caucasian baby, and we found out this time that there's an affected full brother who has 2 mutations, the R553X and the F508. How this is very helpful is we already know our panel would have detected the F508 deletion. Okay, so we go in when we have this clinical information, I can write a totally reassuring interpretation. I can say, since it's a full sibling and these are 2 severe mutations, I predict that this patient is just a carrier of cystic fibrosis. So we don't need to, even worry them any further. Okay, now let's take another case of the same scenario where we found a single mutation, the R553X. Now we find out that this is a symptomatic Asian Caucasian baby who has meconium ileus. So the reason that they really sent it is because not because they knew about anything about the parents having mutations, it's because the baby actually has meconium ileus. As most of you know, that's concerning for cystic fibrosis, and kids should be tested for CF who were born with meconium ileus. Given that we'd only found one mutation, we definitely want to suggest doing full sequencing with reflex deletion duplication tests. We need the best rule out we can get for cystic fibrosis. So again, very different recommendations on all three of these cases based on clinical information provided. And again, we can do these Bayesian analysis only if we know the ethnicity, because, as we said, the detection rate varies per ethnicity. So I'm going to give you a couple examples of prenatal testing for CF using the basic panel and how, again, this clinical information is going to change dramatically what we're going to actually write on the test interpretation. So the result on both of these cases is going to be that we find a single severe mutation. There's the F508DEL, and it's a single mutation and it's heterozygous. So clinical information, we have a Caucasian couple. Neither has undergone cystic fibrosis screening prior to the pregnancy, and there's no family history of cystic fibrosis. So they're just doing this routinely because maybe she's already having an amnio for an abnormal maternal serum screen or age, and they're not anticipating finding anything from their CF results. So when we find a single mutation, it's actually going to make them quite scared because neither one of the couple thinks they actually are a carrier even. So what we want to be able to do is, if we knew that, the information, clinical information provided, we can actually do a little Bayesian calculation and say, the chance this Caucasian baby was actually going to be affected was 1 in 2,500. And then the condition of being affected with cystic fibrosis on the screen, meaning how many people would you only find one mutation in who are Caucasian and affected with cystic fibrosis? And basically 4 out of 5 you would find 2 mutations, and 1 out of 5 you would only find 1. So that's what you use for your conditional information. And it comes out to be a posterior risk of about 1 in 500. So that is the risk I'm actually going to put on the report is, yes, it's higher. It's not the 1 in 2,500 they started with, but it's not real high, okay? Because 2 mutations, the fact that 1 mutation was not identified. So that is actually the information they're going to get on the interpretation is the 1 in 500 that the pregnancy is actually affected with CF. Again, I probably just recommend, unless the child has symptoms, don't go and do any further testing. And then let's go with another prenatal diagnosis. This is a woman who's going in for an ultrasound, and they see an echogenic bowel in the fetus with dilated bowel loops. Well, that's going to be a higher risk for cystic fibrosis, certainly than a person who didn't have any ultrasound anomalies. And again, we're just finding a single mutation, but it's going to be a very different prior risk of having that this baby is affected with CF. It's not going to start off with 1 in 2,500. It's going to actually start off, I'm going to tell them, I'm going to give them a prior risk of 1 in 10 based on not just the echogenic bowel, but the dilated bowel loop. And so then we're going to do a Bayesian calculation, and our calculation is going to result in a risk of about 36% or 1 in 2.8 that this kid is actually affected with CF. So in this situation, I would think that they might even want to consider sequencing. So it's going to, again, this takes you through the Bayesian, but what I'm trying to get at is if you provide this clinical information, how different the result interpretations are, and how, for instance, the CDC thinks that this lack of information on these reports that we're providing isn't helpful, that we just say, 1 mutation identified, because we can't interpret it without having this background information. Okay, I'm going to switch gears to another disorder to give you an example of, again, how information affects interpretation. So, quick background on MCAD, or medium chain acyl-CoA deficiency, of dehydrogenase deficiency. So it's an autosomal recessive disorder causing inability to metabolize fat for energy. And it's on newborn screens across the country because it's a very treatable disorder. You just can't fast. You have to have something given some energy all the time. You can avoid the horrible consequence of sudden death. There happens to be one very common mutation that's responsible for 90% of abnormal alleles. So oftentimes there might be a panel, a couple mutation panel that's looking for this common mutation. 80% of affected people will have 2 copies of that mutation. But people need to be aware, again, this panel is not going to pick up everything. So we had a 3-year-old female, and we found 1 copy of this severe mutation. Again, are we going to put out a report that says we think she's a carrier? And, we need to know what's going on. So we call and we find out she has a newborn brother who was just diagnosed with MCAD through the newborn screening, and he's a compound heterozygote for the common mutation and actually a very rare mutation. So we will interpret this as the patient is at least a carrier of MCAD and may be affected since this other mutation is not detected by the panel. So we recommend that the best practice, if we had known this information ahead of time, is to actually do a targeted sequencing test where we were just looking for both of those mutations in a targeted way just because of having the family history. So that child is still at risk. And then with case 2, we have MCAD panel and organic acids ordered on a newborn girl. And again, we have the same result. We had a single mutation in this newborn. Clinical information is there's a 3-year-old full sibling that died with GI illness and dehydration that was found on autopsy to be homozygous for the A985G mutation. That's very helpful to us because now we can say this patient is predicted to be an unaffected carrier because it's a full sibling, and we know if we would have picked up 2 of those, and we didn't. There was only 1 there. So that enables us to make a very secure diagnosis. Or recommendation, you could say, that of what we feel like is going on in this particular case. So in summary, reviewing these genetic test orders can result in significant cost savings. I've just talked a lot about molecular examples, but it's across the board in cytogenetics, biochemical, any genetic test. That kind of information up front is very helpful. Genetic counselors are ideally trained to perform these genetic test order reviews. If you have some at your local facilities or anybody you can use, I highly recommend it. Clinical information is critical for reviewing these tests and to interpret them. So the medical directors and genetic counselors who are trying to make these test interpretations really can't do it or do a very good job without having this clinical information. So it's very critical for that as well. And I want to acknowledge the genetic counselors here at ARUP that were very much, I couldn't have done this talk without them in that they were just as much as me hands-on with reviewing all these test orders and test interpretations. So again, thank you, Sim. So the first question I see says, can your electronic medical record locate clinical data on a patient's relative? Both in the case that the relative was seen at your facility or not. I am thinking about familial mutations and syndromes here. So what I would say is, because that's, I guess, a few questions altogether. I would say that I don't have access at ARUP to the medical records at our local university hospital, much less any of the hospitals across the country where we're getting these samples from. We do have certainly records, you could say old test results from other relatives that we can use if it's talking about a child under the age of 18 whose then parents want to be tested for a familial mutation, and we are glad to do that, or vice versa, a parent who's been tested who wants their under 18 child to be tested. But we cannot, because of HIPAA, look up a record on a family member of like a 57-year-old woman who wants whose daughter, who's 20-something, wants us to go, test for my mom's mutation. she was tested at ARUP. We cannot do that. So you would have to have a records release from the other lady for us to look that up or provide that information. So most of the time, unless it's a parent-child scenario, we really need you to show us that you know what the result is, because we just can't legally look it up. So I'm going to go to another question, see if I understand it. With the event of direct-to-consumer genetic testing, is it appropriate to ask if patient has had direct-to-consumer testing done, like for instance 23andMe, or the test needs to be done in any case to have a clinical result? Okay, I would say this sounds like it's coming more from a practitioner point of view, where maybe the patient is coming in with a direct-to-consumer result for you and wants to know what to do. I would say that you do have to have the test redone in a clinical laboratory, because the 23andMe test, I think they're claiming that they're not even doing medical testing. So I would say you definitely want to redo these types of cases in a clinical lab, especially if you're going to act on these results. I know there are several tests that are done by 23andMe that have very significant results, such as their BRCA testing. And I would feel like before I went ahead and made any drastic medical decisions or counseling, I would want that confirmed in a clinical laboratory. So I hope that's helpful. All right, the next question says, am I understanding correct that when testing for the infant with CF, why would a deletion not be detected by sequencing? Yes, you are understanding correct. So when there's a very large deletion, more than, for instance, let's say 20 base pairs, I'm just making that up, you can always call a laboratory and find out how large the deletion is, where there's a problem where we can't pick it up. But if it involves a whole exon, or exons like 7 and 8 and 9 and 10, or the whole gene, we're not going to pick it up by sequencing, because sequencing can't tell how many copies you have of a particular exon. So imagine it as you're reading 2 volumes of Harry Potter Volume 1, and you're asking me if anything missing, and all I can tell you is that I'm not reading any errors in chapter 1, 2, or 3. I just can't tell how many copies I have of 1, 2, and 3. Because if I have at least one of the books there, I can read through every chapter. And so if there's a large deletion, like a whole missing chapter, I'm not going to see it with sequencing. You are only going to pick that up with copy number type technology, which requires the deletion duplication testing. So if a very small deletion, like F508, a 3 base pair deletion, we're going to see that on the page of the book, because it's not going to miss something that just looks like a typo. I hope that answered your question. There's the next one. Would adding the frequency of the Lynch syndrome gene mutations on the form help the healthcare providers decide what to order? Would listing the cost of each test on the form help the healthcare provider? I don't think so. The reason why is because, at least not the cost. The costs are actually very similar for each of the Lynch syndrome tests, but I want them to make the decision based on the IHC and the PCR results if possible. If someone's had a cancer, I don't want them to rely on the MLH1 and MSH2 more commonly have mutations. I want them to do the other preliminary testing that can be a couple $100 to guide them to the specific single gene that is more likely or not to have a mutation, or to be told that we don't think this is a hereditary cancer. On the other hand, if they are just going to go through the test one by one, definitely I would start we actually do call people and encourage them to kind of go from like MLH1 and MSH2 to the less frequently. But we have to fit everything on one page on a patient history form. So we have to decide how to, but I agree that, definitely some of the genes are more commonly causing the problems, but I would like them to do other preliminary tests first, I think. And I've got about 2 minutes left, so let's see. This will probably be my last question. It says, what are the delays that are incurred because you need to review all the genetic test orders? How efficient can the system be with larger and larger volumes? Okay. Well, we have about 3 genetic counselors on molecular test reviews every day. And it takes us, it's variable, obviously, every day how long that takes us. But I would say a good 4 to 5 hours that we spend just those 3 genetic counselors reviewing molecular genetic test orders. How efficient it could be, I think it could be very efficient if we got the patient history forms with the test. Meaning if we didn't have to call the practitioners very often, we could review them, put that to the medical director so they have the clinical information. We could quickly decide if it's the right test. I think it's more efficient when you get that information. When it's not, we are getting larger volumes like everybody else, and we're able to still do it. And I think it's because we think it's so critical. When you see 28% of times you're changing tests, you feel like you can't just not do it because it's a big job. So we continue to work hard to review these. I don't know what the answer is in the end, except for getting that clinical information. And that's what this conference is all about, to try to tell you how important it is to drive it home to your local doctors that when you're ordering genetic testing, please submit clinical information.
Thank you for providing our audience with this additional perspective on the significance of collecting appropriate patient information when ordering genetic tests, as well as the impact on the result interpretation. Your discussion on the challenges and opportunities facing laboratories and healthcare providers in the area of genetic testing, I'm sure, will be useful as we are experiencing increases in both the ordering of genetic-based tests as well as their associated costs. So on behalf of Chris and ARUP Laboratories and its Institute for Learning, we'd like to thank everyone for participating in this educational event and invite you to view more self-directed educational content at arup.utah.edu. Thank you, everyone.